Welcome to Pediatric Case Review. Today we'll explore acute cerebellar ataxia in children, a condition general pediatricians should be familiar with. This lecture will cover clinical presentation, diagnosis, management, and include case studies to enhance practical understanding. Let's begin our exploration of this important pediatric neurological condition. A previously healthy 3-year-old child presents with sudden onset inability to walk steadily for 2 days following a viral illness. What is the most common presenting symptom of acute cerebellar ataxia? Is it A. Fever and seizures, B. Gait disturbance and falling, C. Visual hallucinations, or D. Focal weakness of limbs? The correct answer is B. Gait disturbance and falling. The hallmark clinical feature of acute cerebellar ataxia in children is a sudden onset inability to walk or maintain balance. Parents typically report the child was previously well, then suddenly became unsteady, falls frequently, and may appear to be drunk. This often follows a viral illness by 1 to 3 weeks. A 4-year-old boy develops unsteady gait and slurred speech. When is acute cerebellar ataxia most likely to occur in relation to a viral infection? Is it A. During active infection, B. 1 to 3 weeks post-infection, C. 3 to 6 months post-infection, or D. No relation to infections? The correct answer is B. Acute cerebellar ataxia typically occurs 1 to 3 weeks following a viral infection. This suggests an immune-mediated pathophysiology rather than direct viral invasion. Common preceding infections include varicella-zoster virus, enteroviruses, Epstein-Barr virus, and influenza. This post-infectious timing is important for diagnosis and distinguishing from direct central nervous system infections. A 5-year-old girl with new-onset ataxia is being examined. Which examination finding is most consistent with cerebellar pathology? Is it A. Increased deep tendon reflexes, B. Intention tremor and dysmetria, C. Sensory loss in lower extremities, or D. Extensor plantar response? The correct answer is B. Intention tremor and dysmetria. Classic cerebellar findings include intention tremor, dysmetria on finger-to-nose and heel-to-shin testing, dysdiadochokinesia, and nystagmus. Importantly, children with pure cerebellar ataxia typically have normal strength, normal deep tendon reflexes, intact sensation, and normal plantar responses, which helps differentiate from other neurological conditions. Which pattern of neurological findings best characterizes acute cerebellar ataxia in children? Is it A. Asymmetric ataxia with cranial nerve palsies, B. Symmetric ataxia with normal cranial nerves, C. Ataxia with altered consciousness, or D. Ataxia with sensory deficits? The correct answer is B. Acute cerebellar ataxia typically presents with symmetric involvement affecting all limbs equally, with normal cranial nerve function except for possible nystagmus. Importantly, consciousness and cognition remain intact. This pattern helps distinguish it from more serious conditions like posterior fossa tumors, which may cause asymmetric findings, increased intracranial pressure signs, or cranial nerve involvement. What is the most common underlying pathophysiologic mechanism of post-infectious acute cerebellar ataxia in children? Is it A. Direct viral invasion of cerebellar tissue, B. Autoimmune response targeting cerebellar cells, C. Cerebellar ischemia from vasculitis, or D. Metabolic dysfunction from viral toxins? The correct answer is B. Post-infectious acute cerebellar ataxia is primarily caused by an autoimmune response targeting cerebellar cells, particularly Purkinje cells. This occurs through molecular mimicry, where antibodies against the virus cross-react with cerebellar tissue. The resulting inflammation causes temporary dysfunction rather than permanent destruction of cells, which explains the generally excellent prognosis with complete recovery in most cases. A 4-year-old presents with acute onset ataxia, normal mental status, and recent varicella infection. What is the most appropriate initial diagnostic approach? Is it A. Immediate brain MRI with contrast, B. Lumbar puncture before imaging, C. History, exam, and basic labs with MRI of atypical features, or D. Empiric antiviral therapy while awaiting tests? The correct answer is C. For a child with typical post-varicella cerebellar ataxia, start with thorough history, physical examination, and basic laboratory tests. Brain MRI is indicated when there are atypical features such as altered mental status, focal neurological deficits, asymmetric findings, persistent headache, or progressive symptoms. Lumbar puncture may be considered if meningoencephalitis is suspected, but is not routinely needed in classic cases with normal mental status. What is the most common finding on brain MRI in children with acute cerebellar ataxia? Is it A. Diffuse cerebellar enhancement, B. normal imaging findings, C. Cerebellar hemisphere mass, or D. Hydrocephalus? The correct answer is B. In 50 to 70% of children with acute cerebellar ataxia, brain MRI findings are completely normal despite significant clinical symptoms. When abnormalities are present, they typically include transient T2 hyperintensities in the cerebellar cortex that resolve with clinical improvement. The primary role of neuroimaging is to exclude alternative diagnoses such as posterior fossa tumors, acute demyelination, or stroke. A 6-year-old with acute ataxia undergoes lumbar puncture. Which cerebrospinal fluid finding is most typical in post-infectious cerebellar ataxia? Is it A. Normal CSF, B. Marked pleocytosis greater than 500 cells per microliter, C. Significantly elevated protein with normal cells, or D. Positive CSF PCR for enterovirus? The correct answer is A. Cerebrospinal fluid analysis is typically normal in post-infectious acute cerebellar ataxia. Some patients may show mild pleocytosis, usually less than 50 white blood cells per microliter, or slightly elevated protein. CSF viral studies are usually negative in post-infectious cases since the mechanism is immune-mediated rather than direct infection. Significantly abnormal CSF should prompt consideration of alternative diagnoses like meningoencephalitis. A 5-year-old boy presents with 2 days of ataxia following a viral illness. His neurological exam shows isolated cerebellar signs with normal mental status. What is the most appropriate initial management? Is it A. Immediate intravenous steroids, B. Intravenous acyclovir, C. Supportive care and observation, or D. Intravenous immunoglobulin? The correct answer is C. Most cases of post-infectious acute cerebellar ataxia are self-limiting and resolve without specific treatment. Initial management focuses on supportive care, close observation for symptom progression, and safety measures to prevent falls. Physical and occupational therapy may help with balance and coordination during recovery. Immunomodulatory treatments like steroids or IVIG are generally reserved for severe or prolonged cases, not as first-line therapy. When would immunomodulatory therapy be considered in a child with acute cerebellar ataxia? Is it A. All cases as standard treatment, B. Severe or prolonged symptoms, C. Only with positive autoimmune markers, or D. Only in children under age 3? The correct answer is B. Immunomodulatory therapy may be considered in cases with severe symptoms, significant functional impairment, or symptoms persisting beyond 4 to 6 weeks. Treatment options include corticosteroids, intravenous immunoglobulin, or rarely plasma exchange. However, evidence for their efficacy is limited, and treatment decisions should be individualized, ideally in consultation with pediatric neurology. Many children recover completely without immunotherapy. A child diagnosed with acute cerebellar ataxia shows improvement after 3 weeks, but has mild residual symptoms. What percentage of children have persistent neurological deficits at 1 year? Is it A. Less than 10%, B. 20 to 30%, C. 50 to 60%, or D. Greater than 80%? The correct answer is A. Less than 10% of children with acute cerebellar ataxia have persistent neurological deficits at 1 year. The prognosis is excellent, with most children recovering completely within 2 to 8 weeks. When residual symptoms occur, they are typically mild and may include subtle incoordination or learning difficulties. Initial severity and longer duration of symptoms may predict a higher likelihood of residual deficits. Which condition is most commonly associated with acute cerebellar ataxia in children? Is it A. Diabetes mellitus, B. Prior viral infection, C. Hypertension, or D. Epilepsy? The correct answer is B. Prior viral infection is the most common association with acute cerebellar ataxia in children. Varicella-zoster virus is the single most common cause, accounting for approximately 25% of all cases. Other common viral associations include influenza, enteroviruses, Epstein-Barr virus, and rotavirus. Less commonly, acute cerebellar ataxia may follow immunizations or occur in the context of parainfectious conditions. A 6-year-old presents with progressive ataxia, headaches, and vomiting for 3 weeks. Which diagnosis is of greatest concern? Is it A. Post-infectious acute cerebellar ataxia, B. Posterior fossa tumor, C. Benign paroxysmal vertigo, or D. Medication side effect? The correct answer is B. The presentation of progressive ataxia with headaches and vomiting over 3 weeks strongly suggests a posterior fossa tumor. These red flags, progressive worsening, persistent headache, and vomiting, are concerning for increased intracranial pressure. Unlike acute cerebellar ataxia, which typically improves over time, symptoms from a brain tumor progressively worsen. This clinical picture warrants urgent neuroimaging to evaluate for a space-occupying lesion. Which of the following is least likely in the differential diagnosis of a child with acute ataxia? Is it A. Acute disseminated encephalomyelitis, B. Guillain-Barré syndrome, C. Diabetic ketoacidosis, or D. Drug intoxication? The correct answer is C. Diabetic ketoacidosis rarely presents with isolated ataxia as a primary symptom. Important differential diagnoses for acute ataxia include acute disseminated encephalomyelitis, which typically has additional neurological deficits and altered mental status, Guillain-Barré syndrome, which presents with ascending weakness and areflexia, and drug or toxin ingestion, which should be suspected based on history and access. Other important considerations include opsoclonus myoclonus syndrome and acute cerebellar stroke. A 4-year-old girl presents with 3 days of unsteady gait following varicella infection 2 weeks ago. She has symmetric ataxia, normal mental status, and nystagmus. Complete blood count and basic metabolic panel are normal. What is the next best step? Is it A. Brain MRI with contrast, B. Lumbar puncture, C. Supportive care and close follow-up, or D. Initiate corticosteroids immediately? The correct answer is C. This case presents a classic picture of post-varicella cerebellar ataxia with appropriate timing after infection, symmetric findings, and normal mental status. In the absence of red flags like altered consciousness, focal deficits, or signs of increased intracranial pressure, supportive care and close follow-up is appropriate. Parents should be counseled on fall prevention, expected course, and when to seek immediate care. If symptoms worsen or fail to improve within 2 to 3 weeks, further evaluation would be warranted. How long should a child with acute cerebellar ataxia be followed after symptom resolution? Is it A. No follow-up needed once symptoms resolve, B. 3 to 6 months to ensure no recurrence, C. 1 to 2 years with developmental assessment, or D. Lifelong neurological monitoring? The correct answer is B. After resolution of acute cerebellar ataxia, follow-up for 3 to 6 months is recommended to ensure complete recovery and no recurrence of symptoms. This follow-up should include assessment of coordination, balance, fine motor skills, and age-appropriate developmental milestones. While most children have complete recovery with no long-term sequelae, a small percentage may have subtle motor or cognitive challenges that should be identified early for appropriate intervention. Thank you for joining this pediatric case review lecture on acute cerebellar ataxia in children. Remember that this condition typically presents with sudden onset ataxia following viral illness, has a characteristic pattern of symmetric cerebellar findings with normal mental status, and generally carries an excellent prognosis. Be vigilant for red flags suggesting alternative diagnoses. If you found this information valuable, please follow our Pediatric Case Review channel for more educational content. Leave your questions in the comments below, and we'll address them in future videos. Thank you.